Hey, all right, Meg. I just wanted to show you these couple studies. I know you've been kind of filling me in on a friend of yours who's got some disc protrusions or herniations or maybe a little bit of both. And I think you've probably shared with that person that you have something similar going on in your lower back. And I'm not sure if I shared this with you. I think I did, but I have two very large disc herniations in my lower back. Probably the onset was probably when I was 13, 14. Definitely had some severe sciatic acute stuff going on in high school and in college when I played football for a while there. And then finally had an MRI. Actually, I was in chiropractic school and then shortly in practice. But I've got two that are really big. They're about the size of your pinky fingernail, or at least my pinky fingernail, which would be a surgical case, quote unquote a surgical case back in the day. But now good orthopedic surgeons, good neurosurgeons will tell you not to do surgery unless it's the very last resort. And there's quite a few studies, and I'll just share two of the most recent ones on why that is. One, surgical procedures inherently have some risks to them, but once you go in, you can't take it back. Residually, they're going to leave some scar tissue, and sometimes that scar tissue actually adheres to the nerves themselves, which is not a good thing. 30 to 40%, especially when you're talking about fusion, sometimes a little bit higher, result in something called failed low back surgery syndrome, meaning the patient's the same or worse off in the surgery. Now, sometimes it is necessary. There's something called limitations of matter. The body can only do so much. The body has recuperative healing powers. But once it gets to a point, sometimes surgery is necessary. But unfortunately, that's, in my opinion, that avenue, and the research is quite clear, by the way. The medical research is quite clear. They're begging these medical docs, don't do the spinal surgery. Do these conservative things first, because there's too many people having surgeries that haven't done the conservative approach first, and a vast majority of people get better with the conservative care. So let me share these couple of studies with you. And I've been doing this for almost 20 years now. And in my experience with disc herniation patients, whether it be cervical or lower back, they're spot on, if not a little bit better as far as percentages in our offices, because we do some other things that most chiropractors don't. One is specificity, and two, some of the anti-inflammatory protocols that we do. So this is a very important study because it looks at lumbar disc herniations, MRI confirmed. And what happens when you send to a chiropractor that does things similar to what I do as far as adjusting style. Like I said, our percentages are probably a little bit higher here because we also do some of the laser stuff, now some vibratory protocols, as well as anti-inflammatory protocols, meaning omega-3s, omega-6s, which just talks about too. So what this is looking at people with symptomatic lumbar disc herniations, protrusions, these are herniations with same-sided radiculopathy and neurogenic changes. So let's take 148 patients with low back pain, leg pain, and physical examination abnormalities consistent with herniations. They followed them looking at a stress rate questionnaire, which is the level of pain, but it's also quality of life questionnaire. This is just in 2014, by the way. Again, in order to qualify, you have to have moderate to severe leg pain, dermatomal pattern, meaning you have sensory changes in that same-sided leg, meaning if you have a left-sided herniation, that in the left leg you'd have symptoms of dermatomal changes, which is numbness, tingling, abnormal sensation in that extremity, a symptomatic spinal segment, and one of these, if not all of them, decreased sensation to cold, pinprick, meaning you're numb, decrease in muscle strength. You couldn't raise your toes. You couldn't do your big toe as strongly as you should be able to. You couldn't stand up on the calf or do calf raises as many times as on the opposite side, and or loss of reflexes, meaning there's some significant neural compression. That disc is pushing up on the nerve. And what they did is they had these folks, these 140-some folks, 148 go to chiropractor, who adjust very similarly to me. And at 1 month, and now there's research now that I didn't pull out, I apologize, that looks at even more chronic patients, which I'll share with you, but you have to, like I said, I could get the reference for you, but I don't have it right here. At 2 weeks, the acute group had an 81% improvement. Chronic group, 47%. The longer it's there, the longer it takes to correct. That makes sense. 3 months down the road, 95% improvement in the acute group, 82% improvement in the chronic group. And at 12 months' time, it stabilized at about 87.5%. Those studies are remarkable. If you look at injection studies, which they talk a little bit about here, if you look at injections going in with epidurals and injecting steroids and painkillers right into that area where that disc herniation is, they have about a 30% success rate. So this has about 300% more success rate than injections. Now, if you look more at this study, I'll flip this over real quick. The chronic pain patients, the chronic leg patients, the chronic radiculopathy and neuropathy patients, the compressive neuropathy it's called. Those are the ones that are extremely challenging. Those are the ones that have had it for a long period of time. They had significant improvement. And the injection studies that I just talked about, that talk about 30% getting better, that's 30% of people getting some improvement, is what the study shows. This is significant, 90%. A large percentage of acute and importantly chronic disc herniations treated with adjusting have relevant and improvement with no side effects. Spinal adjusting is very safe and very cost-effective option for treating symptomatic lumbar disc herniation. 90%. This study would suggest that all patients suffering from lumbar disc herniations with compressive neuropathy should be treated by chiropractic before anything else is done. There's a study that I don't have here that shows that they took took patients with lumbar disc herniations that on average had had them for 7 years. I think there was 102 people in the study. All 102 had been declared disabled. They weren't working. They were collecting a disability check, and they were incredibly miserable. 7 years, the average duration, and they sent these folks to a chiropractor, and after 3 months of consistent chiropractic care, I think the number was close to 75% were completely taken off a disability, with another 10% that had marked improvements, but they were still labeled disabled, but pain levels had decreased, the function of their legs had increased a great deal. And it was interesting, this caveat with this study was, these patients had been to physiotherapists, they had been to chiropractors, and been to medical doctors in the past, and they said to this chiropractor, what did you do differently? They've been to other chiropractors, and obviously you do different things than physiotherapists, and Meg, we do that differently in our office too. The chiropractor said, with the chronic people, what we needed to do is we needed to see them for 3 months, but especially for the first 2 to 3 weeks, we need to see them daily for 2 to 3 weeks. We needed to break that habit, that pattern. And by seeing them for 2 to 3 weeks every day and then decreasing the frequency of care to 2 to 3 times a week for the remainder of that 3 months, he had that remarkable change. I mean, taking people who were literally declared disabled and getting them back to work in 3 months' time. That's pretty incredible. This study just came out in 2016, May of 2016. 85% of people with sciatica have herniated discs, which is what your friend has. Disc-related radiculopathy is both biomechanical and biochemical. The biomechanical is the disc pushing up against the nerve. The biochemical is the consequence of this, meaning the inflammation that's in there. So not only do we want to get the pressure off the nerve, we want to treat the inflammatory or address the inflammatory process by looking at the omega-3 to omega-6 ratio. Too many Americans are hyperinflamed, so when they do have a disc issue, which is bad enough, it becomes even worse because they lead pro-inflammatory lives. So we look at omega-3s and doing some low laser level therapy and stuff on them as well. Most patients with radicular sciatica who do not undergo surgery will improve. 6 weeks of conservative therapy is recommended with patients with herniated discs in the absence of neurological deficit. Major neurological deficit. That means those nerves that also control the leg and pain in the lower back also control colon and bladder. So loss of bladder function, loss of ability to control one's bowels is considered a major neurological deficit. Conservative treatment does not change the natural history of disc herniation, but offers symptomatic relief unless they have major neurological deficits or they don't respond to conservative therapy. Basically what it's saying is don't even think about surgery. The mean resolution time of sciatica symptoms being caused by the disc is 12 weeks, 3 months, like I mentioned earlier. No advantage of surgery over conservative treatment for relief at 1 to 4 years follow-up, meaning, hey, I've had this for a while. I want surgery sooner rather than later. What this is saying, if you have it sooner rather than later, 1 year and 4 years down the road, it doesn't make any difference if you delay the surgery, meaning try conservative care first. By 1 year, outcomes of early surgery generally do not differ from those of prolonged conservative therapy, meaning, hey, if you get significant results after 3 months of conservative care, stick with it. Because if you get surgery, prolonged conservative therapy is just as good, if not better, and I'd argue better. And for those who could choose conservative treatment, what it also shows is there's not a therapeutic window, meaning, hey, if I don't get this done in a certain amount of time, I'm going to have permanent consequences because of that. No, there is no absence. There is an absence of a therapeutic window. So it means you can prolong it, meaning try other things first. And again, I shared that study with people with 7-year history of disability. 95% of disc herniations are L4, L5, and L5S1, majority here. This is the second most. Really limit the use of opioid drugs because of lack of benefit, evidence of benefit, and a growing concern for long-term adverse effects, meaning addiction, as well as damage to your liver and kidneys. Plus, it doesn't fix the problem. That's why I wrote it right there. It doesn't fix the disc problem. Injections, no significant advantage over placebo for pain relief or reduced rate of surgical intervention. So not only do they help about the same lines of placebo, the injections, it doesn't do anything to change the rate of surgical intervention in the future. And there's no advantage with respect to improvement in physical function. I mean, you can't touch your toes more, you can't sit for longer periods of time, all that fun stuff that we've all been through that have disc herniations. Our quality of life doesn't improve with injections as well. This one shows the randomized controlled trial, not the one I just showed you, by the way. A different one showed manipulation adjustments was more effective than home exercise and placebo at 12 weeks. And this is another study that showed that at 6 months, people with MRI-confirmed disc protrusions, not a herniation, protrusion. Protrusion generally is something not as significant, still significant, but not completely herniated. Herniations are a little more challenging, but still we get 90% success rate. At 6 months, those that went under chiropractic care is looking at absence of pain. Those that didn't had almost a 3 times greater reduction, a 300% more chance of complete resolution of pain than those who did not undergo chiropractic care. There's an inflammatory component to radiculopathy. We talked about that earlier. Omega-3s, low-level laser therapy, looking at chiropractic adjustments. Looking at 3 months of care with specific chiropractic care, the 87% success rate. And there's some other comments here. Now, interestingly to us as chiropractors, and we knew this, we've known this for 100 years, this study, which we hope changes the playing field for us, is this study was actually just published in the New England Journal of Medicine. So, you know, there's sometimes a rift between chiropractors and medical doctors over the years, and traditionally over time, it's, you know, since I've been in practice, it's gotten better and better. We both, at least the physicians I work with, both realize we are very good at certain things, and we kind of stay in our, we call it staying in our lanes. This is our lane. This is my lane. Disc stuff is fun for me to see because it's something that for a lot of people, they think they don't have any hope of getting any resolution other than surgery, but most people don't want to undergo surgery because statistically, one, the correction rate and the pain rate is decreased. Once you go in, it's never the same. Failure rate is much higher than we'd hope. Plus, if you're doing any sort of fusion, you lose mobility and all kinds of fun stuff. And plus, the consequences of doing some of that surgery is if you do a surgery, the levels above and below those discs wear out over time too. Again, sometimes completely necessary, I think in my 20 years of practice, I've had less than a handful of people that actually needed to go in for surgery. So hope that helps. I got a little long-winded. I apologize. It's about 15 minutes. So I'm going to get this uploaded to YouTube, and I hope you find it informative. Take care. Thanks.